respected chairperson, respected senior members of the faculty and fellow delegates. This is an offbeat topic. It is hepatoblastoma. It is mainly a pediatric topic. But nowadays, this hepatoblastoma is being referred more and more to HPB surgeons and GI surgeons because of the new age advances. The reason behind this is the overall 5-year survival of hepatoblastoma was only 35% in 20th century, whereas it has improved to more than 75% in last 2 decades. So this improvement in survival is because of highly effective chemotherapeutic agents, better understanding of the liver anatomy, better anesthetics and post-operative care, and of course availability of liver transplantation. So most of the management of hepatoblastoma is based on the recommendations of any of these guidelines. The COPL guidelines, that is mainly US, mainly European, and Children's Oncology Group, COG, is mainly US. So this is the COPL pretext staging for hepatoblastoma. The pretext means pre-treatment extent of the disease. It is a pre-operative system based on radiological assessment. It's very simple. Pretext 1 means it affects only one sector of the liver. It is based on the sectoral anatomy. Pretext 2 is 2 sectors, 3 is 3 sectors, and 4 sectors. So that is pretext staging. If there is a venous involvement, it is called a V+, portal vein involvement P+, metastasis M, rupture H, N nodal involvement. So this is a simple pretext staging system that is used to assess the pre-operative workup. So the COG system is post-operative surgical pathology staging, mainly by the US. Stage 1 is a complete resection. Stage 2 is incomplete resection with microscopy. Stage 3 is incomplete resection with macroscopic margins. And stage 4 is distant metastasis. So based on these, they do a risk stratification. So just concentrate on the COPL guidelines. They basically divide the patients into a standard risk and high risk. Standard risk is pretext 1, 2 or 3 without any venous or portal involvement, whereas high risk is pretext 4 with any of the either portal vein involvement, venous involvement, distant metastasis or anything else. So standard risk and high risk. So to identify the CCT, the investigations are simple. It is usually the ultrasound in postpartum or during pregnancy. And for evaluation of hepatoblastoma, we do a CECT of the abdomen and pelvis liver protocol, and CT of the chest is a must because 20% of the patient presents with lung metastasis on the same presentation. An AFP is, of course, it is needed. It will be very high in the range of lakhs, and biopsies usually done because neoadjuvant chemotherapy is now the protocol. So MRI is not that much helpful even though in literature, because in kids taking an MRI is very, very difficult practically. But CT is of no use in usual circumstances. The treatment plan in US is based on the Children's Oncology Group guidelines. Pretext 1 and 2 tumors, they do a primary resection. Pretext 3 and 4, they go for neoadjuvant chemotherapy followed by surgery. Whereas the rest of the world, especially the Europe, Asian countries and all, they follow the COPL guidelines. They advocate neoadjuvant chemotherapy for all patients. It is based on the observation that the response rate of chemotherapy is almost 90%, that is one. Second thing is the risk of tumor handling and resectability is better after chemotherapy. And they will take care of the occult micrometastasis without any delay. And third, another factor now that is coming up is the liver resection itself can produce some of the liver regeneration and promote the growth of occult metastasis because of liver fetal growth factors. So because of this, based upon the COPL, most of the guidelines now recommend neoadjuvant chemotherapy in almost all cases of hepatoblastoma. So this is the chemotherapy regime. So you can follow the COPL regime there. So if it is a standard risk patient, they give a single drug, CDDP, cisplatin, 4 cycles followed by surgery. Whereas if it is a high risk case, they give CDDP and added with doxorubicin that we call the PLADO regime. PLADO means cisplatin plus doxorubicin, PLADO. Plus cisplatin 4, doxorubicin, PLADO, or super PLADO if it is a very high risk thing, 4 cycles followed by surgery. So for the surgical principle, So usually done after neoadjuvant therapy nowadays. So size of the tumor alone is not a contraindication for resection. Tumor resectability depends on the surgical expertise, good anesthesia, OT facilities, and the goal of surgery to achieve complete resection with negative margins. So anatomical resections are usually recommended because the segmental follows the segmental anatomy. Fortunately, children tolerate major resection better than adults. So you can go for extended hepatectomies, you can go for liver resection with contiguous multivessel resections, you can do hepatectomy with IVC thrombectomy, and those kind of things children tolerate better. Liver transplantation, there is a definite indication if it is not resectable, especially pretext 4 tumors or pretext 3 tumors with major IVC involvement or main portal vein involvement, central tumors, all these are indications for liver transplantation. Even the lung metastasis, they respond very well to the intensification of chemotherapy. So see, the complete response rate after chemotherapy alone for lung metastasis is to the tune of 40%. So if it is not disappearing after chemotherapy, you can still do a metastatectomy. So this is the survival following in cases of lung metastasis. So in COPL4, the 5-year survival rate is to the tune of 45%. So it ranges from 40 to 60% even in patients with metastasis. So prognosis is based on so many criteria like pretext group, the metastasis, AFP levels, histological subtypes, completeness of the resection, and clinical stage of the disease. And the prognosis is nowadays is excellent. That is, the 5-year, 3-year survival rates are 75%, 80%. Pretext 1-2 lesions, it is something like a complete cure. There are kids who got operated in 80s and 90s and still living. So this is our own data from RCC. So we started very recently, just 1.5 years back, because nowadays the reference to HPB surgeons are more because of the chemotherapy responses. We did almost 15 cases. So mainly left hepatectomies, right hepatectomies, extended hepatectomies we have done. And the morbidity is less compared to adult patients, only there is no mortality. Morbidity is in the tune of 9% from our data, and all the patients have remission so far because it is the maximum follow-up is only 21 months. So while planning the surgical resection, it is mainly the anesthetic consideration which are very, very important because these are all small kids, 1 month, 1.5 months, 2 kg, 3 kg kids. So the proper lines, anesthesia care, that is the most important thing. And intraoperative management while doing liver resection is also going to be very tough thing. So these are the things that actually produce good results. So this is the resections, mainly the right hepatectomies. The tumors will be so large, the size of the tumor is not a contraindication as we have already discussed. So this is extended hepatectomy specimens. So large, very large tumors. So sometimes it presents with large tumor reaching up to the pelvis, and they are not contraindication for surgery if you can do a safe surgery with adequate remnant liver. So this is not a non-anatomical resection because of the size of the tumor. Sometimes you will have to do something like these resections. So this is a case where the patient presented with there is a tumor inside the atrium. You can see the tumor. There is a tumor inside the atrium. You can see because it's a left-sided hepatoblastoma with IVC tumor extending up to the right atrium. So in such cases, actually, we can plan something like a combined resection. So this we did along with the Srijitra people, where the surgery was done under cardiopulmonary bypass, where they have opened the right atrium and took out the tumor thrombi from right atrium, and also the IVC thrombus was cleared, and later proceeded in the same sitting itself we proceeded with left hepatectomy. And this patient we did 18 months back, still living, and the child is very active and with no evidence of diseases so far. So this is why this hepatoblastoma is important in nowadays, because it's been with the chemotherapy also it has got excellent prognosis and good outcomes. Thank you.